OMFS elective recovery workshop on oral and maxillofacial surgery. It's a tight 2 hours, so I will be ensuring that the speakers stick to time. And I've just got a bit of quick housekeeping before we start. I hope everybody is okay with the meeting being recorded. Donna is in charge of our AV. The usual rules for Teams-based webinars, if people could keep their microphones muted, then we don't get feedback. Because of the time frame, if people could put questions in the chat box, and we will answer those later. But I don't think there's quite the time for that. If Donna spots a particularly urgent question in the chat box, we will address that. But generally, we'll try and address those later. And that's about it, really. I'm going to hand over to Steve Hodgson, who is one of my colleagues at GIRFT, who's a clinical ambassador for the Northwest, to outline the aims of the meeting and to introduce all our speakers. So thank you, and hope everybody enjoys the meeting.
Yeah, so thank you, Neil, and thank you everyone for attending what I'm confident will be a very interesting, and I don't see why not, a very useful meeting. I'm Steve Hodgson. I'm, as Neil says, GIRFT Clinical Ambassador for the Northwest. With the particular, I'm a simple orthopaedic surgeon from Bolton. During that GIRFT job and in previous leadership roles, I've had a particular interest in all surgical specialities. And certainly enough to understand how important oral surgery is. I really do want to say that GIRFT's improvement work is going to be fully aligned with supporting restoration of surgical services, including oral surgery, to meet the challenges that we face. Next slide, please, Donna. First message, I think, is to say that oral surgery is not alone in facing this big challenge. So that's a graph that you've probably seen in the national press of the total number of patients waiting for surgery and outpatient appointments across England. A couple of points to highlight in there is you see the dip in referrals around wave one. There's recently been a steeper increase than before COVID as we start to see patients being referred back into the system. But I think the main message from that slide is that it's not all about recovering from the pandemic back to where we were. We clearly were struggling even before COVID. So we should, instead of talking about elective recovery, we should be talking about transformational restoration. And that's why I think, that's why I've put opportunity on that slide, because I think that is the big opportunity we have to really transform our services to deliver what our patients require. Next slide, please, Donna. What is different is, unlike before the pandemic, we now have a lot of patients who've waited more than 52 weeks. Some of those waiting for surgery, but many of them waiting for a first outpatient appointment. And it's really important that we have a plan to start to get those waiting times down as soon and as safely as we can. Next slide, please. Other things have happened since the pandemic, and I draw your attention to that document around the future of integrated care systems in England. It's fair to say regional and system level planning is now back, which I think is a good thing and will certainly be focused on supporting elective recovery. The ethos within the Northwest is that it is system by default rather than creating a big regional tier. It is the 3 individual integrated care systems that will really drive planning of healthcare delivery over the next few years. There's been a real change from competition to collaboration. Many benefits demonstrated during the pandemic, how we dealt with that, particularly mutual aid around critical care capacity. But there's a really big focus within the ICSs where we work closely with on population health, and particularly ensuring equitable health across their populations. And that includes equity of access to surgical services. But probably the key part of that document is that the ICS clinical strategy will be driven by specialty clinical networks. And I really want this to be probably the key output of this today is that we get our managed clinical networks for oral surgery, or clinical reference group, as I understand the Greater Manchester ones are going to be called, back up and running, fully supported and really focused on that transformational elective recovery. Next slide, please. I've written this slide based on my 5 years as a medical director in Bolton, and I think it's probably fair to say for executives across the NHS really that oral surgeries feels complicated to non-oral surgeons or oral surgeon business managers. So that does give oral surgeons and their business managers great power, and clearly with power comes responsibility. But I do strongly feel that the challenges that we face require solutions developed by those clinical teams, and the system support will be there to meet those solutions as long as they're patient focused. Next slide, please, Donna. So that's the overall objectives, which I think is more our objectives as an improvement community over the next year or two, really. That's around maximising our existing resource, and I'm no doubt hear of some examples of really good practice over the next 2 hours, but we should always striving to achieve best quartile efficiency. It's about shifting activity to the left where possible, so from main operating theatres into procedure rooms. All the other surgical specialities, their main volume of patients waiting for surgery require daycare surgery, so there will be competition for main operating daycare facilities. And if you can't move it from main operating theatres to procedure rooms, where there is an opportunity to move from hospital to community where that's safe and there is capacity, then that's also something that I think will be very strongly supported. Final slide from me, Donna. So the aims for the event, it really is about understanding our current challenges, and that will be a key thing that we can gain from this. Identifying and learning from and spreading best practice, and then collaborating to develop those solutions. And I would hope by the end of this 2 hours, we are starting to develop and agree some solutions that we can then take to our managed clinical networks and clinical reference groups to do that. The breakout sessions have been designed deliberately to put people in their managed clinical networks. And we really hope that's an opportunity for you to develop the solutions that we can support you taking forward. The output of those breakout sessions, we will give you all the opportunity to feedback, but we will certainly capture it and share it with you after the event. So welcome. Thank you for the organisers for putting it together and for you two attending. And we really look forward to a really useful 2 hours. So that's over to Nick, who's going to share the oral surgery data on top of that national data.
So thanks, Steve. Just before I ask Nick to give us an overview of the situation, I've seen a few things in the chat box that hopefully people have managed to resolve the issues by logging out and logging back in again. And yes, Donna, can we make sure we share all of our slides with all of our delegates today, please?
No problem. Yeah,
that's great. Okay, so it's over to Nick, who is the clinical network lead for the Northwest, and he's going to give us a quick overview to build on what Steve was saying there.
Thank you very much. And just to add to that, I used to be a dental contract manager. I am based in Langston, South Cumbria, and I'm the network lead, clinical network lead over in there working in primary care. And although I have been contributing to this event and working with my colleagues across the Northwest to pull this together. So my job, I guess this afternoon, is just to kind of do a bit of scene setting. Obviously, there's lots of data and there's our understanding of the world as we see it today. But within the data, what you don't get is anything that talks about all the hard work and effort that everyone's put into keeping the system afloat and keeping patients out of pain through last year and into this year as well. And I know from my conversations with colleagues who are working in trusts and in primary care, it's been difficult and it's been very challenging. And I think from a commissioning point of view, we absolutely acknowledge that and thank everybody for all of their hard work. And like I say, The data doesn't tell you anything about that, but I just wanted to get that out there so we have that as at the front of our minds. And like I say, thanks again.
I always stick up for us.
Live TV, there's nothing like it. Can you, whoever it was, could you go on mute, please? Okay, let's get on with this. Next slide, please. So an overview of where we are at the moment. So basically, this isn't news to everybody. Our understanding of the world, we got impacted by COVID. The infection prevention regime that was put into place, AGPs and the challenges that brings, the fallow period, the social distancing, all of those have an impact on services, not just in secondary care, but also in primary care. And that's led to a very challenging environment through which we have to deliver care. It's essentially, keeping it really simple, we cannot get the throughput through our trusts and our clinics. And that's led to this backlog of patients and the challenges we're going to talk about today. And to illustrate that, we're going to look at some of the data from various sources, and many of these charts will look familiar to everybody. So if you could flick on to the next one, please. So there's probably, if you're working in health and social care, there'll be a chart that looks like this somewhere in every department, basically, which shows everything was going along as normal, and then it drops off a cliff as we went into the first lockdown, and then slowly things start to recover. Here's some information we got from our referral management provider, FDS. This just illustrates the referrals going into secondary care from oral surgery, and you can see they're broken down by each of the ICSs. The lines drop off at the beginning of April last year. They go flat for a while, and then they start to recover as services start to go up. And the take home from that is that we're not quite back to the level we were at before, and that's something we need to keep at the forefront of our minds, that we're not, from the data we're looking at, we're not necessarily in the same level of throughput. So we need to keep thinking about that as we're making our plans. Next slide, please. This is the next few slides are about the waiting list information. This information we collect from our assurance team. Your good cells provide this information through. Here's a list of everybody who's waiting for oral surgery, treatment function code 014, oral surgery. And that's a summary of how things have been since the end of February, beginning of March. You can see we've got an increase. The scale on the side will give you an indication that it's gone up by not just shy of about 2,000 to 3,000 patients in the last few months. Next slide, please. Broken down to each of the ICSs, you can see it's a similar pattern. Nobody is running away with success. We've all got that inflation on the waiting lists. It's different sizes, but the rate is that the direction of travel for the waiting list is in fact upwards. Next slide, please. Here's a view from some data we got from Model Hospital. Essentially, this is patients waiting over 52 weeks. Just bear in mind that the circles aren't to scale between the three ICSs, they're to scale within each of the ICSs. So you can see again, we've got people waiting over 52 weeks. Some trusts have more, some have less, but the problem is across the whole of the Northwest. And I guess that's where our thoughts need to be today. It's not necessarily about individuals, it's about collective systems coming together and trying to think about collective solutions, because that's the only way we're going to kind of really dig ourselves out of this position, I feel. Next slide, please. That's similar data that we just looked at before in terms of the waiting list. This gives you an indication of the rate of waiting list inflation, if you will. So looking at the data that we receive on a weekly basis, you can see there, taking February as our kind of like a baseline, if you will, how the waiting lists have moved over the weeks as they go by. Looking back as more people have got onto the list, you can see that rate of inflation. Green bar being the Northwest total, Cheshire, Mersey, Lancashire, South Cumbria, Greater Manchester. Greater Manchester being a bigger geography, having more patients, it mirrors and follows the Northwest total quite well. Cheshire and Mersey, a lower size, a smaller size of waiting list, but that inflation rate seems to be out of step with the rest of the patch. Again, something to bear in mind when we're thinking about solutions later on in our workshops. Next slide, please. Here's the same data again, and I was in two minds whether to keep this one in or not. It does look a bit busy. It's the same waiting list in figures in terms of the rate of increase, but I've just overlaid on top of that the actual size of the waiting list. So it's those two pieces of data we looked at before, kind of mashed together to give an indication of the scale of the challenge in front of us. Next slide, please. So on to thinking about and looking at what's been going on in secondary care. Again, many trusts, many departments will have something similar to this. There's 3 pieces of data here. I'll just take you through each one. This is across the Northwest. So the first block of data talks about how on a monthly basis, how the activity has been flowing through the trust. It also has the previous 2 years worth of information as well. So you can see the dark blue line is the year we're just concluding, and the previous 2 years are the lighter blue lines there. The next block of data shows activity this year compared to the previous year. And again, it's no surprise, is it, that April and May were really challenging times where we didn't get anywhere near what we were doing. But the recovery starts to bed in as those blocks get smaller and smaller. We get close to the similar kind of levels of activity that we saw the previous year. And indeed, when you get through to February and March, we start to get into that kind of positive increase in activity going up and exceeding what we had last year, which is kind of where we want to try and focus our minds on. And the final block of data is the running sum, which gives you that cumulative impact, cumulative figure of activity going through, and that gap that you can see is the challenge that we're trying to address today, or trying to get early thoughts of addressing today. So three sets of charts, all presenting the same data in a slightly different format. And if you go on to the next slide, please. We'll just have a quick trip around each of the ICSs. You'll see that all of these slides, the next couple of slides, are all very similar, portraying the same thing. The only thing that really changes is the gaps and the distance in the data. And again, for Lancashire South Cumbria, the same information there. So we're going to have a quick look at some more slides. I'm not going to read these ones because there's quite a bit of data. We sent out a questionnaire to each of the trusts, and thank you very much for those that managed to complete that. I've summarized the data where possible, or just copied and pasted it verbatim. It gives us a bit of an understanding about what's going on out there within trusts. I mean, you'll know yourselves, but it's helpful to understand how other providers are doing. So let's go look at the first cut of data. So the first question was, what are the main procedures making up your oral surgery waiting lists? I'll let you have a quick read of that. I'm sure there are no surprises there. You see it's similar kind of things across each of the trusts. Have a look at the next one, please. These next 3 slides show number of clinics or capacity in February 20 compared with current capacity, portrayed in slightly different ways depending on how you interpreted the question, but largely speaking, you can see there's no one's got this massive increase of resources that they've been able to tap into. It's pretty much the same level of resources pre-COVID as it is now, and therein lies the challenge. If you've got that similar volume of patients coming through, you've generated a waiting list, how are we going to manage to address that waiting list in terms of you've only got the same resources, same estate, same premises? That's where the challenge starts to emerge. Next slide, please. Same look at the information. This is about minor operating waiting sessions per week. And again, you can see, numbers on the left, pre-COVID, numbers on the right. It's tempting to say post-COVID, but we're not post-COVID, are we? We're still in the middle of COVID. Next slide, please. And again, same information, except this is day-to-day theatre lists. Next slide, please. And there was a few questions which talked around other things that were on the list. So the first block of data is about children under the age of 12 waiting for extractions with tooth decay. And some of the trusts which answered no, that's because their lists are largely handled by a community dental service or a specialist paediatric service. The other bar chart shows the question was, do you offer maxillofacial skin service? And if so, how many on the waiting list? And again, not every trust replied to this. So whilst the figures for patients and those yellow diamonds may look a bit low, that not every trust has replied. And then the final chart at the bottom talks about orthognathic surgery and whether you deliver orthognathic surgery as well. Next slide, please. So moving away from the data and thinking about going forwards, obviously we've, as commissioners, people have been talking to their respective trusts and starting to get some ideas and thoughts together. And this is ultimately a bit of trying to distill those thoughts down into the various stages and stops on the pathway in that kind of highest sense of the word. So thinking about initial referral and allocation, thinking about the types of referrals that are coming in, is there a way of managing things differently? I know that from some of the trusts I talked to in my area, they've been really pushing on with the advice and guidance clinics. There's the people have been doing a lot of this kind of teams talking and maybe being able to talk to patients and providers prior to them making a referral, but also the challenge about persistent poor quality referrals going in. Are we still seeing that kind of thing going on? So thinking really about the referrals coming in and the allocation of patients into oral surgery, is that right, or is there something we can do to improve that? The second bit we were thinking about was around the waiting list themselves. Are we really sure that everybody on that waiting list actually still needs to have an oral surgery procedure? We know that there's been a really good response from the from the GDPs in terms of setting up the urgent dental care networks. I can't remember how many it is. I know there's 60 or so in Lancs and South Cumbria. There's similar, numbers comparative in Cheshire, Mersey and Greater Manchester. The GDPs have been doing their bit as much as possible to keep patients out of pain. There's a feeling that maybe some of these patients who've been waiting, more than 12 months may have drifted into one of the urgent care centres and have that tooth extracted, but they're still on the waiting list. So there's potentially some discussion about how we can perhaps maybe do a waiting list cleansing exercise or contribute to that, and have some thoughts around how we might go about doing that. The third bit is thinking about where we have that extra capacity for, and again, some of the conversations that I've got on with trusts have explained that, there's theatres have been taken from us. We're fighting over access to, GA sessions. There's not enough people or time of the day to do this. We can't get these patients through. Is there anywhere else we can go to tap into additional resources? We know that in primary care, there's a vibrant minor oral surgery service that operates across the Northwest, and many of the maxillofacial and oral surgery consultants will do clinics in there. We don't fully utilize their skills. We only operate up to level 2. Is there some work that can be done to maybe harness those skills and deliver more in a primary care setting, letting the consultants, work higher into that kind of level 3 type of procedure under local anaesthetic or under, sedation in a primary care site? And our final thoughts were, kind of a bit of the out of the box thinking about what is it we can do to widen capacity in primary and secondary care, even thinking about the kind of pop-up clinics, mobile units, Vanguard sites, utilization of the independent sector. It's thinking about along those lines. I think what I want to get to in the breakout sessions later on, and I think the there's obviously consequences for some of these activities, but we need to get that buy-in and those early thoughts down so we can take those through a governance process and get funding released to move things on. If we can go on to I think it's my final slide. Yeah, so this is think along those lines. These are the questions we're going to work through in our workshop in a wee bit. So it is about the initial referral and allocation. Is the right patient arriving in secondary care, or can we do further to develop tier 2 pathways and reduce people actually arriving in secondary care in the first place? There's that confidence about the waiting list. Now, we're really sure that everyone on the waiting list actually needs to have an encounter in secondary care, or can we do something to support a cleansing exercise, and what does that begin to look like? Again, the third part is what I just talked about earlier on. It's touching on the tier 2 services. We've got that potentially a bit of headspace in primary care. There's definitely capacity in terms of evening, weekend work and doing more activity. Can we push on and utilize those level 3 skills from the consultants that operate in those clinics? And then thinking a bit more about the box, how are we going to, outside the box, how are we going to widen capacity in primary and secondary care if we're going to do that? The joint working, people coming together and thinking about this as a system-wide solution as opposed to individual solutions. So that's, I think, is my slides done. Just to say that when we do the breakout session, we're not using the traditional Teams way of using breakout rooms. There is some instructions within the invite that you've all received, and what we're going to ask everybody to do is actually physically leave this meeting, open up your invite and choose which of the rooms you need to go to based on where you work within the Northwest. And then your breakout session will go through that, 20 minutes going through those kind of questions, and then you'll leave and come back into this main meeting. But if you get stuck, just open the original invite and go back into this meeting, and somebody will signpost you where to go. So I think that is me done. I think I'm just a shade over. Sorry, I was going to try and get some time back for you, Mr. Chairman, but I failed miserably.
Thanks. Thank you, Nick. So I think that's outlined clearly the scale of the problem. We're going to move on to Miss Morton Marie, who is our national GIRFT lead for oral maxillofacial surgery, who hopefully will give us potentially some solutions. Marie, over to you.
Thank you, Neil. So I've got two presentations today, and I'm going to try and clarify some issues around what we're talking about when we are talking about oral surgery, because I can see from some of the comments in the chat that's not clear. And I expect there are a lot of people around the table who probably don't know what we're talking about. So can I have the next slide, please, Donna? So there's a lot of confusion. There are two specialties. There's oral and maxillofacial surgery, and there's oral surgery. Oral and maxillofacial surgery is a dual qualification specialty. It's a surgical specialty regulated by the GMC. The consultants are qualified in medicine and dentistry. There are around 400 consultants in England, and 54 of them are in the Northwest. Oral surgery is a dental specialty. The consultants qualified in dentistry. I couldn't find out how many consultant oral surgeons there are in the country. Most consultant oral surgeons are based in dental hospitals. I think there are 10 within the Northwest, and those who are in the dental hospitals are not wholly NHS. They have academic responsibilities as well. So whatever workload we're talking about, most of this is going to be delivered in hospital practice, secondary care, by oral and maxillofacial surgeons. Let's move on to the next slide. So what's the range of work? So oral and maxillofacial surgery has a huge range of work. Most oral surgeons are work in the area of dentoalveolar surgery. And I'll explain. Dentoalveolar surgery is the surgery around the teeth and the dental supporting tissues in the mouth. There are some oral surgeons who have a wider range of responsibility, but those are few and far between. And there are oral surgeons who work in, as I've said, in secondary care and also in primary care. And we move on to the next slide. So what did the GIRFT process did? So there were two GIRFT processes. There was oral and maxillofacial surgery, which I visited some 79, 80 trusts and examined data from a few more. And there was a national report written, which was published at the end of 2018. And there were 15 recommendations in that report. There was also a report of the hospital dental specialties led by Liz Jones, which covered oral surgery as a specialty as opposed to oral and maxillofacial surgery, plus the other dental specialties, restorative dentistry and orthodontics, etc. So next slide, please, Donna. So what were the recommendations that were relevant to our current position? So one of them was that we moved some of that dentoalveolar surgery into primary care. And this is a reflection of the slide that Steve showed at the beginning. Waiting lists across the country have been going up for years. So yes, there's more patients on the waiting list now as a result of COVID, and particularly long waiters, 52 and even 72-week waiters, which I think we'd all agree is really a very unsatisfactory situation. But before that, it was clear that the amount of dental work, surgical dental work, being referred into departments of oral and maxillofacial surgery was increasing. And some of that should probably be done in primary care. And there's been a lot of discussion around that, about what dentists are trained to do or happy to do these days. And I think Chris Bells will talk a little bit more about that. One of the other recommendations was improving efficiency by organising ourselves in networks. And Steve again has mentioned that. And there was also concern about equal access to orthognathic surgery. It was clear to me as I went around the country, the situation in orthognathic surgery was decidedly variable, with some centres doing lots of orthognathic surgery. It was offered widely in their surrounding areas, and other places doing very little, having huge waiting lists. Back then, I thought that might be due to orthodontic provision across the country, but Liz Jones showed that that really wasn't so. Now we've got COVID coming in, and certainly those orthognathic patients are waiting there with their orthodontics complete, and they're on those long waiting lists. Another one was that we improved theatre utilisation. We're not using day case as much as we should be. Nationally in all sorts of specialties, day case is increasing, and we need to be there. And the suggestion was that we included some of our non-elective work as day case, and I'll talk a bit more about that later. And reduction in follow-ups. And having just produced new deep dive packs, that has been one of the successful recommendations, in that most units have managed to reduce their follow-up rates, which of course creates more room in outpatient clinics to see the new patients. Next slide, please, Donna. So what's GIRFT been doing? So GIRFT is very involved in supporting the elective recovery, using those principles of reducing unwanted variation, sharing best practice, and leading by clinicians. In London, they've been running a pilot. Unfortunately, oral surgery or oral maxillofacial surgery wasn't included, although our waiting lists across the regions are in 5th, 6th and 7th place by size. So the specialties are there that are involved, and essentially it's around the high volume, low complexity work. And GIRFT has produced some guidance on that, which you'll find on the GIRFT website. Next slide, please. So just an example of what can be achieved. So this is the national day case rate trend for procedures that are in the BADS, that's the British Association of Day Surgery directory of procedures. And you can see since the production of the high volume, low complexity, and also the day case guidance, both documents came out by GIRFT. There's been a huge increase in the day case rate for those procedures. Some of that might be due to the recovery happening at the same time, but I think the slide is quite impressive. I think that's the next one, Donna. Oh, yes, sorry, I will just say a bit about the oral surgery waiting list. So oral surgery treatment waiting lists contain patients referred by doctors and dentists, and they require procedures covering the full range of oral and maxillofacial work. And Nick in his presentation referred to the oral surgery treatment function code 140. There's been a lot of debate and issues around that recently. There is another treatment function code, maxillofacial surgery, which doesn't get used very often, but the patients on that are included in national data, although I'm not sure they're included in Nick's data that he's shown you today. There is a new treatment function code called oral and maxillofacial surgery that wasn't going to come into play until April of this year, and I am not convinced that it's being used very widely at this point in time. So essentially, when we're talking about oral surgery in terms of a waiting list, it is oral surgery and oral and maxillofacial surgery, the two together at this point in time. That may change at some point in the future, but at the moment, we're talking about the work that oral and maxillofacial surgeons are doing. The bulk of patients on those waiting lists are high volume, low complexity dental alveolar surgery, which gets referred to both oral surgeons and oral and maxillofacial surgeons. And as I said before, it's around teeth. There is a slight confusion in there in that some trusts includes both special care dentistry, which is a specialty for adults and adolescents with disability, And some also include community dental services, for which are children with special needs, but also the children who require general anaesthesia for dental extractions. This surprised me because in my trust, those patients don't appear on the hospital waiting list at all, but it seems across the country that's very variable, and in many cases, they are on those oral surgery waiting lists. Okay, next slide, Donna. And those are, I just looked through the waiting lists in a different region, and those were the procedures that were on the waiting lists. So clearly the head and neck cancer is getting done, the trauma is getting done, but in here we've got all sorts of things. Salivary, that included removal of parotids and major glands, and it includes orthodontic. So that the waiting list contains the full range of work. Next slide. There we go. Thank you.
Thank you very much.
Thank you,
Marie. Hopefully that's clarified some of the questions that I'd seen in the chat there. Really helpful. So we're going to move on now to Chris Bell, if I could welcome him, who's head of a managed clinical network in the southwest of England, and he's going to talk through what they've done and what their achievements have been, which should be interesting. Chris, can I hand it over to you?
Thank you very much. Listening to the first 20 minutes of presentation is a bit like a Groundhog Day, because we're very fortunate that Marie started a GIRFT initiative with us 6 to 8 weeks ago, and we're quite far along track that you are. So yesterday I led a workshop all afternoon with all the managers for all the main trusts in the southwest and all the clinicians, and we're setting up task and finish groups to address these issues. But moving forwards, if I could move to the next slide, Donna. The really thing I want to work on is, it appears quite by accident, we have a very successful oral surgery MCN in the southwest. I was appointed in 2016 to set it up from scratch. And the main things, as this slide says, the purpose of an MCN is to facilitate patient-centered care, and as said earlier on by Stephen, it's to drive transformational change and to improve clinical effectiveness. What I'd like to say is that you're not to look for the big changes. What you want to do is look for the actual process and efficiency of your procedures, and if you can increase those efficiencies by 4 or 5% in a particular area, cumulatively you end up with a, say, 15 to 20% improvement in process, and that's probably the way you need to go in looking for your oral surgery recovery. Next slide, please, Donna. So the aim, as I say, the minor oral surgery MCN is to offer ways of working where clinicians from all settings across the clinical pathway can get together, focus on patients and improving services. Sorry, it's a repetitive slide, sorry about that. Next slide, Donna. So what does an MCN do? Well, first of all, it must be managed. It has to have a defined structure, a really clear strategy statement, and use of documented evidence base, and be multidisciplinary and multi-professional, and include patient representation. And it should have a clear policy and dissemination of information to patients. So we do that through the Southwest Local Dental Network web pages. Next slide, please, Donna. So they're not new. They've been around in Scotland for 20 years. They've been extremely successful. They were initiated in 2002. For those of you who want to look at how to set up an MCN, I know this slide pack goes afterwards. That link underneath is extremely useful. Initially proposed by Chris Baker in 2002. There was a review of the function of MCNs in the Scottish Health Service undertaken in 2012. And the comment was, they're absolutely essential. So they're here to stay. Marie did ask me to help, what points have I got in setting up an MCN, and I sent her the document that I was fortunate to access. I'm coming to that question. That's nice. That's come up there. Thank you. And how to set up an MCN, and I managed to get hold of the Scottish document. Now, I can't find it on the web anymore, but for those of you after this presentation, if you would like me to forward this to Donna, she can disseminate it. This is the nuts and bolts of setting up an MCN, and without question, I've now found no better guide. I know, Marie, I sent you a copy. I don't know if you had a chance to browse through it.
Thank you. Yes, I did. and it is very, very useful.
Thank you. Next slide, please, Donna. So you need a clear clinical role, a clinical lead role to work where most of that individual needs to be known and have credibility across all parts of the system. And processes need to be in place to ensure that the clinician's role reflected in the job plan. That's really, really important. And if the lead was a medical clinician or that performance appraisal must be an integrated part of the job plan. You need to look at evidence and local experience and indicate for those being on MCNs being supported by the board. And you should be looking at a fixed term where they should have 2 sessions per week, which is what I have. To answer some of the questions that are coming up, I'm funded by NHSEI. They pay 2 PAs a week for me, and they pay directly to my trust. And that's my salary hasn't changed, just that I know one day of my 2 of my PAs are coming through NHSEI through my trust. So therefore, issues such as pension and everything that's not interfered with at all. Initially, I used to work in my office in the hospital, but like most senior clinicians, I'll be halfway through my MCN day and a call would come up, oh, so-and-so has not turned up for their clinic, can you come down and run the clinic? So at that particular point, I had a meeting with the managers and said, I'm working from home all day Tuesday. I can't afford to be interfered with. So it's really important that an MCN lead has protected time, is funded, and it's in the job plans. Next slide, please, Donna. So as I say, it's a minimum. I say a minimum. It's recognized that 2 days a week should be put aside. And along with that, which is what I didn't have when I first started, secretarial data management support is absolutely essential. So when I was first appointed in 2006, I have to confess NHSEI was not that well organized. I had no secretarial support, as did none of the other MCNs, and it took us nearly 2 years to get that. So we were doing most of the work ourselves, including addressing envelopes and actually working out how to print envelopes so that the addresses fitted in the transparent window. For those of you who are going to be setting up MCNs, I would not tolerate that level of lack of investment. It's got to be an absolute, it has to be there. Next slide, please. So this is called clearing the investment. And this has to be done before you even take the first step as an MCN. So that you have to obtain your development of the network, to obtain the understanding and support of the most senior people in your local NHS, that's chief executives, medical and nursing directors, and it would be wise to draft an outline plan of a development plan for the network at the outset. So a reasonable estimate of development costs and timescale can inform the initial discussions, and this can be later serve as a basis for formal funding application and full development plan. Absolutely core this homework is done to start. Next slide, please. And you need to establish a project team. A single person can't do this, so you need a small team of people to drive the process forwards. And I think the smallest team you'd be looking at is a project leader, project manager, secretary and administrator, and much of the development work would also have to involve some senior clinicians. And ideally, your project manager should have a clinical background in management, project management skills, and experience of a multidisciplinary environment, and some experience of managing and improving programs in the NHS. And initially, they will need to be almost seconded to full-time work. Certainly in the Southwest now, we're about to appoint a full 10 PA grade 8 managed clinical network manager for all 6 MCNs, because many of the MCNs share common aims. So we've now managed to get that in place, and I can tell you it's taken 4.5 years to do it. So we've learned the hard way. Next slide, please. So project team working groups, service mapping and care pathways is absolutely essential. Quality standards and clinical governance, administration and finance. Patient involvement is key, and information provision, and IT and evaluation. When I took the post, the Southwest Local Dental Network webpage had not been looked at for several years. It's our main portal for clinicians to go to for referral guidance and for the public. And next slide, please. And you will find that I've put that in one of the latest slides. If you want to go to Southwest Dental Network webpage, you will see unified referral guidance for oral surgery for the whole of the Southwest. That's 7 counties, oral medicine. All the referral forms are there, all the fast track forms there for every single provider in the Southwest, restorative forms, special care, and orthodontics. And I've been the clinical manager of that webpage, and it's been extremely useful to put together. For an example, some of the things, the impact I've had last summer, I phoned around because the fast track forms were all over the place, and I bumped into Plymouth, and their website had put the fast track forms for all surgical specialties on one web page. So I then took that as an example. I contacted all the other major trusts in the Southwest and said, this is what you need to do. And every single trust has now done that. So this is the kind of intervention you can make. Service mapping is absolutely key for us. And what we did, first of all, it may not surprise most of you, when I asked for a list of providers, both secondary care and primary care in the Southwest, the list I got from NHS England was woefully out of date. I've got two very, very good people on the committee, and we set out to do a survey of all providers in the Southwest. And I found out that some of the providers, even secondary care providers, were no longer working in the hospitals that NHS EI thought they were in. They'd moved completely to a different hospital. This is the time lag and lack of information. Next slide, please. So who have I got on my committee? Obviously the MCN chair. You have the local dental network chair. It's absolutely core. We do have referral management systems in the Southwest. I can talk about that later on. Representatives from secondary care. I've got tier 2 primary care providers. I can tell you that following the survey, mapping survey we carried out, 45% of all the minor oral surgery up to level 3A in the Southwest is carried out by primary care providers, with 30% of the workforce of secondary care. That's quite a telling finding. Health Education in England is on the committee. I've got 2 regional commissioners. I've got a clerical support team. We have Health Watch representatives who are key. The LDCs are involved, and it's regionally represented. So when we set it out, we're quite a large region. We chose to have representatives from each region so that within our 7 counties, local general dental practitioners and trusts could turn to an MCN representative who worked in their patch and knew the local issues. That's very important as well. Next slide, please. So the MCN chair is responsible to the LDN chair, and you need to have a well-led, clinically effective LDN chair. Unfortunately, in the Southwest, this has not been the case for the last 2 years. We've now rectified that. Chairs should meet at least quarterly with the chair and commissioners and other MCN chairs outside local dental network meetings, because many common issues are shared. You can pool resources, and we're now finding we've got cross MCN tasks, and we're setting up task and finish groups. For those of you on the call, temporomandibular joint dysfunction management has been a big issue. We've now found out that 40% of referrals go to medical practitioners. And for those of you in commissioning, that's opened up the funding for us to get the ODN involved and look at expanding the way these patients are managed for use of pain clinics, cognitive therapy, and psychiatric support. So this is the impact of a structure like that. Again, with the restorative MCN, we're looking at apical surgery pathway now, the single pathway in the Southwest, which will probably end up being restorative directed first, rather than oral surgery first. So these are the kind of initiatives you can drive. Next slide, please. That's our webpage. Please go and have a look at it. I think you might find it quite useful. If you would like a copy of the updated oral surgery referral guidance, which I have completed in the last few weeks to reflect the work that Jeff Chu did with the new third molar guidance, I can forward that again to Donna for dissemination. Next slide, please. So, as I say, I was appointed in 2016. It took me a year to put the committee together. We undertook process mapping in 2018 and identified all providers and all levels of activity and tariffs, how many staff they had, and that was very, very insightful because NHS England didn't have that. I then engaged with all the Southwest referral management centres. I physically went to meet them. So we've got 2 referral management centres where we've got triaging clinicians on board and 1 where there isn't. So it's knowing what's going on in your patch, which is really important. We reviewed all oral surgery reforms in the Southwest, and we brought them into a common function. We unified the oral surgery and oral medicine guidance document, and we reviewed all secondary care provider web pages and referral pathways. Because if you go and look at your own trusts in your own region, you may find it's quite chaotic. And this led to me holding a Southwest Regional Symposium in 2019 in Taunton, which is funded by HEE. And I got all managers and all senior clinicians under one roof to meet the commissioners. And it was a really good breakout day. We were able to present all of our findings, and it's cemented us together So when COVID hit, I could pick up the team and talk in first name terms to managers around the Southwest, and all that work played out tremendously. And in setting up yesterday's meeting, the same happened. Right, you're preempting my slides. That's excellent. Next slide, please. So the Southwest Oral GMCNs, we merged in February of 2020 because there was, as you know, there was a reorganization of the regions in the whole of the country. So BGSW, which is Wiltshire, Gloucestershire and Dorset, joined our patch. We have now a single MCN, so it's 7 counties wide. It's huge. And when we merged them, we explored existing provision. We looked at identifying the oral surgery issues. We've unified the referral criteria. We're developing options to support and train primary care GDPs. We've got 2 postgraduate courses here in the Southwest and 2 universities. We're looking at consideration of sedation provision because the IASCD initiative of 2015 now means you have to undertake a formal year of training before you provide sedation. We've got huge amounts of sedation in primary care. At my own trust, we do about 680 sedation cases a year, but we have a primary care provider in our city that does 4,200. So give the, and this is where you come into mutual aid at this particular time to look at management of your lists. You develop sustainable, we're looking at developing sustainable intermediate oral surgery primary care options. And we're also looking at oral medicine hub and spoke options for the Southwest because we only have oral medicine in Bristol and none in the lower Southwest. Next slide, please. So the survey, as we said, database held by NHSE was not very good. So we designed a process mapping exercise and we sent it out to all providers. Now, I was off at that time on sick leave for about several months, and I was able to phone up and say, where's the survey? It's a sequin engagement, please, would you please provide it? And you have to badger. And I think if you're going to do a process mapping survey at this stage, you get the commissioners on board and you get the commissioners to drive it so it is completed in a timely fashion, in full, and returned to you. You don't have to chase them up. Next slide, please. So it showed that we got to know all secondary primary care providers, identified all the staffing levels. For me, it established links with the managers of all secondary care units. It also identified oral surgery funding sources, and it was split between NHSEI and the CCGs. It had grown up over the past 20 years. It's messy in the Southwest. And I can also tell you that some of the primary care providers have not had their tariffs upgraded for 6 years. And so it also identified providers that moved hospital-based that NHSEI didn't know about. So this is the value of an MCN. Next slide, please. So we've got 10 secondary care providers in the Southwest, mostly are oral max-fax units and DGHs, and we've got 1 teaching hospital. The Peninsula Hospital in the lower Southwest does not have a service provision contract. As I've said, 19 tier 2 primary care providers. They treat 45% of all minor oral surgery cases in the Southwest. Problems you've got is their funding tariffs, and I know that was in the questions asked. It's a mixture of UDA cap funding, and that's people who were doing oral surgery before the 2006 contract came in, that's capped. We've got IMOS providers where once they've reached the tariff sum they've been given for the year, they can no longer see any further patients. And we've got any qualified providers where it's open and the funding is not capped. Massive split of provision, there's no unification. Next slide, please. So our secondary care providers accept and provide notable tier 2 and some tier 1 activity. Tier 1 activity is really only suitable in teaching environments, and you may wish to say that could include your DCTs, but ideally this should take place in the iOS primary care and not in secondary care. 80% of some of our secondary care maxillofacial providers, 80% of their referral base is tier 2, tier 3A, and it's not good use of highly skilled maxillofacial surgeons. But our primary care providers are limited in numbers by funding, recognition, and training. Next slide, please. So things we've also done, we have a unified PROMS and PREMS rollout from all providers, which is based on MS forms. It's been agreed with the central commissioners, so they can dip in and dip out of hospitals and ask for that data. I don't know whether you have electronic referral systems in the Northwest. We are pushing hard. It's been a major must-have from the MCN chairs, but there's been some dilly-dallying around in the commissioners here. but we've broken through that barrier recently. So we've got the TNJ Working Party. I'm now doing the provider survey mapping of the new part of my patch, which is the Wiltshire-Dorset area. We have driven through implementation of the PHE November guidance, which means that oral surgery drills below 60,000 are non-AGP and there's no fallow time. And that's had a profound effect on patient throughput. But unfortunately, I've got 2 providers who still have an hour's fallow time and still treating everything as an AGP. We've got to ask the question why. And this is where an MCN can step in with the commissioners to say, please justify yourself. As I say, we're looking at oral medicine access to the Greater Southwest region and expanding our oral surgery outside secondary care for Tier 2. Next slide, please. So look at the historical side of things. Most of our Tier 2 providers are called legacy providers. They were carrying out MOS to a high level before the 2006 primary care dental contract. We've had very little chance to commission new Tier 2 providers. Firstly, there's been no money. Secondly, we do not have the Tier 2 assessment panel as set out in the 2019 NHSCI CDO document. And we're working hard with the commissioners to get a central approval panel for Tier 2 and look at innovation to provide them with money to treat patients, because we realize, like you do, this is the way to go forwards. To train a Tier 2 panel individual costs £1,500 per individual, and that has to come from NHSCI. So absolutely important you involve the commissioners with this development. Next slide, please. This was the 2006 explosion in referrals in oral surgery in my area. As you can see, MaxFax hardly blipped, but we had a 400% increase in oral surgery referrals the moment the 2006 contract hit. And for those of you who've been working in oral surgery, you're probably very familiar with that. The new tariff does not pay, UDAs do not pay to do oral surgery. There's been massive de-skilling in primary care. It's not taught to a sufficient enough level in dental schools anymore, and the upward trend of referral is going to continue. Next slide, please. So those are exactly what I've said on the previous slide, and that sums up why we're seeing more and more referrals. Next slide. So defense societies have thrown their pitch in as well. They've often advising practitioners, if you feel it's out of your skill set, refer, please don't do it. So there's another tranche of why we're getting increased referrals, and there's now a really risk-averse primary care GDPs are not uncommon. Next slide, please. The question about tariffs was asked earlier on. Sadly, we have no core IOSS primary care model of funding in the Southwest. As I said, it's either UDAs or historical IMOS Tier 2 providers or AQP providers. Next slide, please. So looking at the funding, my hospital, secondary care, say for a wisdom tooth referral or a tooth that's been decoronated, pre-assessment consultation, 120 to 140 pounds. Treatment under LA, we get 150 quid. If we provide GA or sedation both are classed as day case, that's 600 pounds, and the follow-up is 70 pounds. If you're looking at what the equivalent individual gets paid for the same patient in primary care, 0 for the assessment consultation, which is they don't do them anymore, which is against best interest of patients consenting before they visit. If you're a UDA provider, it's a total of 120 pounds. There's no additional fee for sedation unless you have a specialized contract where you may get paid 55, and there's no funding for follow-up. So you can see the problem and the barrier that you've got to do if you want to move everything back into primary care. Next slide, please. So COVID-19, big impact on us. It's highlighted existing inadequacies. It's really identified good examples of good working across the region, and it's identified the need to look further than just the impact of the pandemic. As Stephen said earlier on, we are using this opportunity not to recover our oral surgery waiting list, but looking to the future. It's very, very important. So what has COVID-19 taught us? Joined up NHS services, very good cooperation between private and NHS providers, and you've got to be flexible with your premises. And here, there's been some good initiatives in the Southwest where they've pooled things with the ICSs onto a single premise. Next slide, please. So your recovery, as Stephen has said, should address the current backlog of patient need. There'll be no quick fix unless recovery also sets out to address the issues that existed before the pandemic. So I do agree with Stephen's opening comments. It's today, recovery must take a long-term view as well as the recent effects. Next slide, please. So looking to the future, COVID-19, it's opened up and highlighted gaps in service provision. It's identified new way of patient engagement, with often telephone clinics for follow-up now. Provides us with an opportunity and chance to look for change and transformation. For most of us, I've been in the NHS 41 years. I've never known an opportunity where main central NHSEI is looking for transformation and wanting to fund it. It's our chance to do it and grab it with both hands. And one thing we are going to do is to look if we can develop an oral surgery service where we want more oral surgery consultants appointed in NHS service contracts to support maxillofacial surgeons in district general hospitals. We may want them to work, say, 3 days in a hospital and 2 days in a primary care intermediate oral surgery unit. Maybe that's overlooked by a trust where they're out with the practitioners. We think that's what we should move for the 21st century. Next slide, please. So, as I say, support for existing secondary care providers. We need more oral surgery consultants. We need electronic referral to enhance triage management. We definitely need a review of Tier 2 services here in the Southwest. And we're really pushing to get these intermediate care oral surgery outreach clinics in the community funded by NHSEI. Next slide. That's what we're looking at. That's the benefits of these clinics. You can take DCTs out there. You can bring GDPs of concern in. And we're also looking to if a GDP wants to upskill, they can book in to do a surgical case with one of the specialists in the clinic. This is our long-term plan, as I say. The big question mark at the bottom is how will this be funded? Next slide, please. And that's the end of my presentation. Thanks, Marie.
Thank you very much, Chris. That was a tour de force on the networks there. Excellent. So quickly, we're going to have a presentation from presumably part of Chris's network on the way the south, I call it the southwest. They're saying it's northeast, Somerset, Swindon, and Wiltshire, about paediatric waiting lists. Donna, are you able to start
that? Thanks, Christine, very much. Can everyone hear me? Yep. So my name is Duncan Murray. I'm an anaesthetist in Salisbury, and I'm the clinical director for the surgery division. And I'll just spend a few minutes telling you what we have been doing in the arena of pediatric oral surgery, particularly, but also some ENT over the last several months. This project came out of a BSW-wide pediatric virtual workstream, which identified a significant problem with children waiting for a long time for pediatric surgery across the BSW patch, predominantly in oral surgery and to a lesser extent in ENT, with wide variation across the 3 provider trusts in numbers waiting and also length of time waiting. And I think particularly within the oral surgery cohort, a concern about morbidity and some of the sort of wider determinants of health in these children who might be vulnerable to restricted access to surgery. There was a recognition early on that the ability for each of those providers to provide high output and high volume, low complexity surgery was hampered to some extent by the estate in certain parts of the region. There was also a recognition that no pediatric surgery was taking place in a children-only environment in any of the 3 hospitals as part of business as usual, but that Salisbury had experience previously of allocating the whole day surgery unit over to children on children-only operating days at intervals throughout the preceding 12 months to provide their pediatric-only environment, if not an actual pediatric customized environment. But the key sort of realization at our first meeting was that there was no site that was properly set up, either in terms of staff, equipment, or sterile services to deliver high volume paediatric oral surgery work independently, and the sort of natural consequence of that was to try and look in how we could work together to make that happen. So next slide, please. So the approach was to Salisbury, the estate most naturally lent itself to trying to do some paediatric oral surgery operating at scale. The ambition was to rotate around sites in BSW, but as I said, it fairly rapidly became apparent that not all 3 provider sites were equally well set up in terms of facilities to do that. There was certainly early on an establishment of some shared ownership of this problem and a willingness to work together across organizational boundaries to tackle the system-wide problem. We effectively merged the waiting list. So although there was quite wide variation, we simply threw them all the children into a pot, so to speak, and started allocating and booking those children who had been waiting the longest. We did this as additional activity, starting on the Easter weekend. We ran lists on Good Friday and Easter Saturday of the Easter weekend, operating from Salisbury on almost exclusively patients from the RUH waiting list. And that first weekend was supported pretty much entirely by Salisbury staff from anaesthetics, theatres, the ward, and surgery, except for one operating surgeon who came over from Bath for that first weekend when we operated on 40 children. We've run a further weekend subsequent to that in the early May bank holiday weekend, where we were able to scale it up somewhat. And there was greater mixing of staff, particularly anaesthetics, also surgery, and some theatre staff and anaesthetic staff, anaesthetic support staff came in from Bath. Sorry, I'm just not able to see the slides myself. And what we had to do for these weekends, because operating on quite a lot of children, we had to, Salisbury itself couldn't support the required instrumentation, both in terms of actual numbers of equipment, but also the ability of our sterile services to turn these over sufficiently rapidly. So we managed to loan some equipment from Swindon that Swindon was accustomed to using in the community and returning to its CSSD. So we relied on the Swindon infrastructure to support instrumentation for these weekends. Next slide, please. So I won't go into the details of what we were actually going to achieve in terms of impact upon waiting times. It was pretty significantly altering the trajectory over which the time trajectory over which these children would have received treatment. As it turns out, we had, and we'll get into this both in this presentation, but also Alistair's, that we had underestimated the volume of work sitting on the waiting list, because it became quite clear that what we thought was primarily relatively simple deciduous extractions waiting for surgery. In fact, there's quite a lot of more complex oral surgery work sitting within that cohort. So in terms of operating time, there was significantly more work to do than we had originally estimated. The ambition, as I say, was to provide surgery in an exclusively paediatric environment, and by pooling the waiting list across the 3 providers, we would hope to reduce the variation in access to care that existed across the 3 provider catchment areas. We anticipated there were opportunities for shared learning in terms of administrative and booking processes. We were reliant on, or we expected to be reliant more than we have been, I think, on paediatric ward nursing staff. So we were hoping to upskill our existing adult nursing cohort in the various providers by having them working alongside registered children's nurses. But we've also found out that there are opportunities for sharing practice, for instance, around anaesthetic techniques, that Salisbury has well-established processes for providing anaesthesia for these low complexity oral surgery procedures that facilitate high throughput on those lists, and some of the Bath anaesthetists have picked up on this and starting to copy those. We recognise that the surgical training opportunities had been significantly restricted by COVID, and by having these high throughput pediatric lists offer an opportunity for surgeons and anaesthetists in their training years to come and spend some time catching up on some of the training opportunities they'd missed out on. And then I think very importantly, just we expected, and I think we have realized how, I suppose in a sense, how easy it is to establish new clinical relationships. Certainly within Salisbury, there's quite a lot of anxiety about the composition, if you like, of our integrated care system, and how the geography of it doesn't lend itself to many of the existing clinical networks and clinical relationships we've traditionally held with our existing partners. And while not wanting to devalue those existing relationships, what this exercise has proven is that there is a willingness and ability to establish new relationships in different directions, and to exploit those for the benefit of our patients. And so sort of following on from that, what this exercise partly for me was an experiment in was just to test, if you like, the appetite in the integrated care system at provider level, and to pilot at some scale the sort of socialization and operationalization of provider level integration across BSW. And some of the things we expected and what we've experienced, and Alistair will expand upon this, you know, the kind of hurdles and issues we've had to confront and deal with, which mostly I think have turned out to be much easier to navigate than we had expected, and that has come out of the enormous willingness and enthusiasm for people in the group that's been working on this to break down some of these traditional barriers to more integrated working. So we've managed to transfer staff across providers with very light touch governance and acceptance. Recognition of standards across the 3 hospitals are acceptable across those 3 providers. So there's been no filling in forms and registering of visiting staff and that sort of thing. It's all been pretty seamless. We were concerned at the start that about the appetite of parents and families to travel not insignificant distances across the countryside from, for instance, the other side of Bath to the other side of Salisbury, and similarly from Swindon. The majority of families that we've contacted have been willing to travel. We've learnt that, or we are learning that non-bank holiday weekends are more attractive to staff and families than the bank holiday weekends, and we've changed our approach on the back of that. But what we were concerned about was increasing inequality by restricting access to care for those children whose families were not able to travel for various practical reasons, and we're making sure that those families that are not able to travel get priority access to surgery at their local trusts. We found it relatively effortless to share waiting lists and transfer booking processes over to the host hospitals, similarly with clinical information and imaging and things like that. It's been relatively easy to achieve. The surgical instruments I've talked about. There's been a willingness amongst within the providers to not focus too much on who's bearing the costs of the financial costs of providing the service. So far, Salisbury has borne the brunt of the additional costs, which are essentially around staff being paid in enhanced rates to do additional work beyond their contracts. But there is an element of shared benefit, if you like, that we are able to get recognition of the additional activity that we are achieving. And as we move towards sort of system bottom lines, then those issues about who's bearing the costs become not unimportant, but possibly less important and less of a barrier. But probably most important of all, as I say, I've alluded to already, is the fantastic teamwork and engagement from clinicians, managers, commissioners in the group that we've been working with to work together to jump over barriers or work around them. and working in an environment where there's been a significant degree of freedom and trust and granting of permission from the executive in the three providers just to get on and do this work. So from I think the perspective of people who have been involved in it, it's been quite rewarding and quite liberating to work within an environment where we have had permission to negotiate these barriers and just get on and get the work done. So that's just a very rapid sort of appraisal of what we've done, how we've done it, and why.
Okay, so that was a recorded presentation we had there from the Southwest. Obviously, I'm aware of time. Marie, we've slipped a little bit, but I think it is important we look at the model health system and the model hospital data, as that's where we get a lot of our GIRFT data from. And then we'll have to lose a little bit of time, I suspect, on the feedback session if we can. So Marie, can I hand it back to you for the time being?
Certainly. We'll get through as quickly as we can. People will have the slides to look at in their own time later. So basically the model hospital, I'm sure you're all aware of the model hospital, but I'm not sure how many consultants look at it. It is becoming much more important, and a lot of the data that we're using in presentations like this around the waiting times, around what you're achieving in terms of whether you're meeting BADS targets, what length of stay is going up on the model hospital. So it's data driven, it's a benchmarking so you can compare yourself with neighbouring trusts. All the GIRFT data metrics are on there, the RTT data is on, and you can compare it, you can look at your trusts, you can look at your system. So the OMFS page will be updated shortly and will contain the new deep dive pack data. I'm going to include gateway metrics, which I'll talk about in a bit. Donna, next slide, please. So the sort of thing you get, these slides are up all the time on Model Hospital. So this one I've chosen to look on across the Northwest region, and you can see what the Northwest region achieves in terms of day case rates for wisdom tooth surgery. And although the differences aren't huge, they are there, and this trust at the bottom could achieve a bit more in terms of its day case rates. Next slide, please. And you can look at it for different things, where this one is fractured mandible across the Northwest region done. This is looking at average length of stay, and you can see somebody down there is achieving a day, and the highest one is achieving over 4 days. So, you know, there's room for improvement there. That frees up beds, etc. Next slide, please. Or you can look at it across the country. And again, this is the day case, this is average length of stay for fractured mandibles looked at across the country. And as you can see, there's a huge variation there with lots of room for for improvement. The black and the grey trusts are the ones in our region. Next slide, please. So what are pathways? So that was just an advertising bit for the model hospital. I would encourage everybody to be looking at it on a regular basis. The data on it is updated now fairly regularly, and very shortly some updated theatre metrics is going to go on, which I think will be interesting. So pathways in the London pilot, which I talked about before, specialties were asked to devise pathways to support best practice, mainly in the high volume, low complexity areas. So in maxillofacial surgery, there are currently 6 pathways. They've all been approved by the British Association of Oral and Maxillofacial Surgery, and the 4 that relate to dental alveolar surgery were also approved by the British Association of Oral Surgeons. All 6 can be found on the GIRFT best practice site, and they are also on the BAOMS website. Next slide, please. So those are what we've got for pathways. So the very simple things, the things that we have masses of on the waiting list. The trauma ones aren't obviously on the waiting lists, but there are areas where there's considerable room for improvement in length of stay. Next slide, please. So I'm not going to go into this in any detail because you won't be able to see it, but this is a pathway for the extraction of teeth in adults, and it starts with the referral in and ends with the discharge, and goes through the whole process. And all the pathways that have been written are in this format. Next slide, please. So what are gateways? So when we've put our metrics up for Model Hospital, we were asked to choose some gateways that would help local systems look on delivering the impact from the pathways. So in oral and maxillofacial surgery, there are some 50 odd Model Hospital metrics, and there are a smaller number, about 10 I think it is, that will be gateway metrics. And in systems that are involved in this elective recovery with certain specialties like ophthalmology and T&O, they are using those gateways to monitor progress against the standards. So you will find those gateways coming up on the BAOMS bit of the Model Hospital very shortly. Move on. Lovely. So these are some of the ones. Yeah, so I was wrong there. It's 26 gateway standards, but 10 of them are standards that are being set from things that I'm asking trust. So most of this data that forms these gateway metrics is stuff that we're picking up from HES and SUS data that's in the deep dive packs. But some of the stuff that I think is important, like, is there a referral management system in place for dental alveolar surgery or oral surgery? And that will be a yes or a no, and it should be a yes. So the standard will be yes, and trusts will, or systems will answer whether they've got that in place. There's a standard around triage, and they're asking, is a member of the OMFS department a member of the oral surgery MCN? It's a yes and a no as well. So those are the sort of metrics and standards that trusts and health systems can be measured against. Next slide, please. So just to look at some of the standards we've set. So the day case rate for wisdom tooth surgery should be 99.6%. We're looking at outpatient procedure rate. Now, tooth surgery, you might wonder what tooth surgery is. It's all the other metrics that are in the deep dive back, like extraction of a tooth, exposure of a tooth, anything that isn't a wisdom tooth, basically. And we are setting a standard that the outpatient procedure rate should be around 70%. That's because we know from the deep dive packs that in some units that is what they achieve. Now, I agree that that will be a standard that depends on having a good triage system, depends on having a good tier 2 service in place, but this will be a target to aim for. And similarly, outpatient rate for wisdom teeth, we know that there are no units achieving more than 50% of that with their referral base. And again, those are the day case rates for fractures of the mandible and of the zygomatic complex that units are achieving. So we're trying to move everybody to the best. That's the end. So that's the last slide. So we can move on. I think we've caught up a fair bit of time. But if anyone wants to ask me more about gateways and pathways, please feel free to email me, and I'll happily do that. I'll put my email address in the chat box.
Fantastic. Thank you very much, Marie. That's great. So I think as we explained earlier, you need to leave this session and then rejoin the session using your the links that will have been included by Donna. It's based on ICS area. We have 4 questions to answer, and if we give it 20 minutes, so we'll reconvene back in the main Teams room at 1:45. And we'll just have 10 minutes of feedback at that time, because I'm sure 2 o'clock is a line in the sand, I'm sure, for a lot of people, really. Is that okay? So we'll see people on the other side of hyperspace or wherever it is.